Science Uncut, presented by the Volkswagen Foundation.
People react quite differently to traumatic events. Some of us can cope and manage to deal with what happened on our own, for example by talking about it with our friends. Others are in danger of being overwhelmed by what they have seen and experienced. When and why someone becomes mentally ill depends on many factors. There's our genetic predisposition, our socioeconomic status, our gender, and our childhood experiences. Pamela Coolins is director of the Office for Research on Disparities in Global Mental Health at the National Institute for Mental Health. In her talk, she argues that we have to look at mental disorders from a global perspective. Poverty, violence, and migration have different effects on the mental health of the population in different countries. Coolins is calling for a true collaboration between rich and poor countries and for engaging the global public health community. Coolins argues that this is the only way to better understand the causes of mental disorders and to fight them. Pamela Coolins gave her talk on April 3, 2013 at the Herrenhäuser Conference Mental Health Throughout Life in Hanover, Germany. The conference was organized by the Volkswagen Foundation. Coolins' talk had the title The Risk of Mental Disorders Throughout the Lifespan: Symptom Progression, Critical Trajectories, and Consequences for Prevention and Early Targeted Intervention.
Around 15 years ago, actually, I was living in Johannesburg, South Africa. And one weekend, friends and I decided to take a trip to the country of Lesotho, which you may know is actually surrounded by South Africa on all sides. We decided to take advantage of a long weekend. And at the time, Lesotho had recently finished its presidential election, and there had been protests on the news. My friends and I asked our colleagues whether or not it was safe to travel there, and everyone told us, of course, people don't riot on a Friday afternoon. And that was true. We drove through Maseru into the hills of Lesotho, and we spent a very lovely weekend hiking and spending time in the mountains. On Monday morning, we drove back, and en route to Johannesburg, we drove through the capital city, and I sat in the front seat of our rental car next to my friend Debbie, the driver, and we saw people on the street. A child in a school uniform. It looked pretty normal. We continued to drive, and we began to see more and more people. And pretty soon we realized that we were actually driving into a crowd. And as we drove, the crowd thickened. And we saw angry expressions on people's faces and people making gestures and shouting at us. And in a minute, our car was surrounded. Young men actually sat down in the road in front of the car, and we were not able to go forward. Others took large cinder blocks and brought them crashing down into the sides of the car. Someone took a baseball bat and swung at our back window, shattering the entire window. And somehow we were guided out of this mob by friendly bystanders and then helped by an ambulance that happened to be driving through the crowd. And they drove us to the border. Once we were back in Johannesburg, several hours after the event, my main goal, and I think the goal of my friends as well, was to stay together and try to deal with the pain of the event. We tried talking first, and we tried alcohol next. A week later, the anxiety diminished. I found myself driving in a rural Eastern Cape village. I was doing a research project which led me to travel around South Africa. And I was driving, I saw people milling on the street. There were a couple of policemen stopping the traffic, and I felt this growing unease. And as I got closer and closer to the people on the street, I was actually forced to turn around and drive in the opposite direction. It just felt too uncomfortable to keep going. 2 weeks after the event, I was in Cape Town, and it was an unseasonably sunny day, and I picked up my rental car and drove around, tentatively at first, driving a bit further, and then decided to just drive down to the Cape of Good Hope. And I remember that day to this day because it was such a beautiful and peaceful day, and I didn't feel that terrible sense of anxiety that I had felt in the previous couple of weeks. So I went through a traumatic event, and like many people, I did not develop a disorder. It's possible that I did not have the neurocircuitry that might increase my vulnerability to developing PTSD, nor am I one of the 1.5 billion people who lives in areas affected by fragility, conflict, or large-scale organized criminal violence, who are more likely to have been repeatedly exposed to traumatic events. And nor was I someone who was consistently exposed to interpersonal trauma or other chronic adversities in childhood, thereby increasing my risk for disorder. But I am a member of an ethnic minority group in the United States, where the complex of socioeconomic status, race and ethnicity, social and historical context, genetics and health disparities interact to produce significant differences in mortality, but also differences in the course and outcome of mental disorders and in access to care. And like you, my education, my income, social network, neighborhood, health behaviors influence my vulnerability and protection from disease and death. Global health is now conceptualized as a field that explores some of these issues. It's a field that places a priority on achieving health equity and provides a hope for reducing disparities that we have struggled with for quite some time. As you've noticed, I've put a mark saying that global health is not the same thing as what we used to refer to as international health. Global health emphasizes interconnectedness, our interdependencies, and is informed by globalizing influences. But it also stresses the unique social, political, environmental, and economic circumstances in individual settings. And global mental health applies these same principles to the treatment and prevention of mental disorders, again, with an emphasis on equity and human rights. So global mental health has its roots in epidemiology, transcultural psychiatry, which have led to an interesting evolution of this field. More than 100 years ago, Emil Kraepelin believed that comparing symptoms of mental disorders across cultural settings was one route to understanding the mechanisms of these disorders. Epidemiologists subsequently applied diagnostic criteria using standardized instruments to measure the frequencies of disorders across settings, but focusing on identifying core symptoms. So epidemiology taught the field about neurobiological vulnerabilities, but also about social vulnerabilities to mental illness. And anthropology has examined social context as a whole in more depth, seeking to explain the particulars of illness, focusing on the differences in the course of disease, patterns of help seeking. And the question for all has been, how do we investigate complex disorders like these in ways that faithfully contextualize illness and the illness experience, allowing for comparative analysis? So both of these approaches and others are obviously needed and become particularly important in the context of treatment. So I think there's consensus that mental disorders are ubiquitous. They cause a tremendous burden of suffering. There's a need to scale up quality services in low-resource settings, whether those are in high, middle, or low-income settings, and to reduce the treatment gap, the number of people that are in need of care but aren't not actually receiving care. And as I think about global mental health, I think these questions around how to accomplish this are among the important roles for researchers as well as service providers. But why is all this important? So I'm sure many of you have seen the recent Global Burden of Disease study, which reminds us that as a group, mental disorders are among the leading causes of disability globally. And this is a slide that's showing you the years of life lived with a disability by cause and age. It's in the early years of life, adolescence and early 20s, where these disorders begin and actually can cause, as you all know, a lifetime of disability. And they account for almost 25% of years of life lived with a disability. And equally important, I think this is particularly important in the global health community, is that these are disorders that carry this burden across high, middle, and low-income countries. And as you can see on the x-axis, these represent regions of the world. And this, again, the red represents mental disorders and the burden of disability, which is somewhat constant across the world. And just to remind you, the disorders highlighted in yellow are mental disorders, which account for the largest number of years lived with a disability, or the greatest burden of disability. And these include major depressive disorder, anxiety disorders, schizophrenia, alcohol use disorders, bipolar disorders, and dysthymia. However, this brings us back to the question of equity. Partly due to the dearth of human resources, almost half of the world's population lives in a country where, on average, there is one psychiatrist or less to serve 200,000 people. So given the burden of disease, given the burden of disability, we clearly have issues with respect to meeting the needs. And this is a slide that shows, in green, high-income countries and the availability of specialists, and in amber, which is not even visible on some of these slides, the availability of specialists in low-income countries to deliver services. So you're looking at some of the differences between countries, but even within regions, we see quite striking differences. Within the Eastern Mediterranean region, for example, there's a 20-fold difference in the number of psychiatrists between Sudan and Iran, with Iran having just over 1 per 100,000 and Sudan having just over 0.05 per 100,000. And a recent WHO study of 58 lower and middle income countries estimated that nearly 240,000 additional professionals were needed in these countries to adequately care for the high burden of disorders in the population. A lack of funding for mental health services may partially account for the lack of human resources. So globally, spending on mental health is less than $2 per person per year and less than 25 cents in low-income countries. So these are the kinds of inequities that call for some kind of action. So I want to go back to the thinking about the world, but also reminding us that in our own local contexts, we need to think of ourselves in terms as part of this world, as part of the global context. And I'll use the example of the United States. And why would we want to think about global mental health issues in the context of a wealthy country? Well, one reason is that we are actually the number one receiving country for immigrants in the world. About 12% of our population was foreign-born in 2009, and about 1 in 5 people are either first or second generation immigrants, first or second generation U.S. residents, I should say. And our last census showed that we are growing even more diverse, with a 43% increase in the Asian population and a 43% increase in the Hispanic population. And this is a slide that distorts countries, the land mass of countries, by the number of immigrants that they receive. And you can see that the U.S. is kind of bloated, as are several countries in Europe. And in the United States in particular, mental health disparities often occur along these dimensions of race and ethnicity. And this slide shows us a couple of things. First, that it shows us disparities in depression treatment by race, ethnicity, and by education. On the whole, about a third of people in need of treatment are not receiving it, but blacks and Hispanics receive less care compared to whites. And given the growing diversity of the United States, it's critical for us to understand and address these problems. And at the same time, we also struggle with developing an adequate mental health workforce. And though the magnitude of the problem is certainly nothing like we just saw in low and middle income countries, there still are significant numbers of practitioners that are needed to achieve targets for adequately reducing the burden of disease and for delivering care. And where there is insufficient access, the stakes are high. So in the poorest countries, lack of access may mean terrible human rights violations. In the richest countries, lack of access may mean worse. I mean, certainly in the United States recently we've had some very dramatic demonstrations of what can happen when people do not have mental health problems recognized and treated. These are also very costly disorders. This is a study from the Global Economic Forum that showed that the global cost of mental health conditions in 2010 was estimated at about $2.5 trillion US dollars, with the cost projected to surge to $6 trillion by 2030. In addition, these disorders have implications beyond simply the problems of mental health. People living with mental disorders have greater morbidity and have other comorbid illnesses. So there are several studies that have shown, both large ones in the US as well as in Scandinavia, have shown that people with mental disorders die from 8 to 20 years earlier than the general population. In particular, the disorders to which people are susceptible include cardiovascular disease, diabetes, HIV infection that co-occurs with mental illness. So not addressing mental disorders leads to losses on a global level too. In 2015, the world will evaluate how successful it was in addressing the Millennium Development Goals. These are the 8 international development goals that were established in 2000 by member states of the United Nations. And 4 of them are specifically health-related: reducing child mortality, reducing maternal mortality, and combating HIV/AIDS, malaria, and other diseases. And we know that mental health is relevant for each of these. Certainly, maternal mental health is critical for child survival. There is strong evidence that maternal depression is linked to outcomes in children, poor outcomes in particular in infants, like preterm birth, low birth weight, undernutrition in the first year of life, higher rates of diarrheal diseases, and early cessation of breastfeeding. We have sufficient evidence linking HIV and mental illness, where co-occurring depression and mental illness and HIV can increase morbidity and mortality among people living with HIV. The lack of mental health inclusion in things such as the Millennium Development Goals has real consequences when it comes to countries and their ability to budget and obtain funding to support mental health services. So I've defined global mental health and pointed out its emphasis on health equity, illustrated why this matters across countries and within countries. And I want to move to the next portion of thinking about what difference can we make if we can envision ourselves as a global community committed to cooperation in terms of research and solving health problems. What kind of changes can we see? Potentially huge changes. So this is a curve that I think, depending on how you look at it, it can represent triumph or failure. And this curve represents the years of life lived with a disability, both in 1990 and in 2010. And you can see it's not so important to differentiate the curves, but it's important to notice that the curve continues to go upward, which means 2 things. One is that people are, as you can see, the age 80 is the highest age on this particular curve. So it means that people are living longer, but as we live longer, we have increasing amounts of disability. So one way to interpret this is to say, wow, we actually haven't done much to improve disability as we grow older. On the other hand, this curve also shows us that donor and country investments that were targeted to the Millennium Development Goals have led to huge successes because people actually are living longer. People are living longer, and this was a huge mechanism for global cooperation. And I think this is one curve that both encourages us as researchers in the field of mental health to say that, you know what, we need to change this. We need to be able to show how investment in mental health research can actually lead to reduced disability, but it also is evidence that global cooperation to actually fix health problems can be successful. But I think in order to do this, we need to think differently, and this requires a shift in the way that we do business. So global health this new kind of global paradigm working together requires us to view the ways that we collaborate quite differently, to adopt an emphasis on co-development and bidirectional learning, meaning that rich and poor countries learn from each other, that this is as much about receiving innovations from low and middle income countries as it is about translating successes from high income countries to these settings. It's about research competence, which really begs us to think about what are the implications of being active participants in a global community? What does that mean for research? How should our practice of research change? Research competence, which is a term I'm coining kind of based on Nigel Crisp's definition of clinical competence, but this occurs through true collaboration when patients, communities, policymakers work with researchers, where the end users of research help to set the agenda. It may mean giving up power on the part of the principal investigators of research. It means establishing partnerships before the start of a research project so that it can have true public health relevance. And similarly, funders, and I'm including us, the funders that I work with, need to acknowledge the needs of end users as well. It means working out truly collaborative research partnerships when resources are unequal across team members. It also means ensuring that global mental health research workforce is truly global, that it consists of people from high-income, middle and low-income countries, people from majority and minority groups within countries, and that we develop sustainable, organized paths to research careers. This may sometimes mean allowing for non-traditional paths to research. People working in NGOs, for example, may have better access and knowledge of communities where research is meant to be conducted. It also means addressing institutional barriers to global mental health as a research career option. So this is the kind of foundation that we need to establish and build upon in order to take advantage of global cooperation. And an immediate impact should be a change in this image to something a bit more equitable. This is a representation, again, by landmass of scientific publications. And as you can see, there are many bloated northern countries and very skinny southern countries where, even as collaborations tend to grow, this diagram needs to shift. So other advantages of this kind of global cooperation means that we find solutions from around the globe. Innovations continue to occur in settings with the most limited resources, and we can learn from these. And this is one example. This is an example of task shifting or task sharing for delivery of mental health services. There's an increasing evidence base that is showing us that by using training workers who don't have the training that specialists do, we can extend mental health services in places with few resources. This is work that at NIMH we've thought about. And when I came to NIMH 3.5 years ago and began to think about what sort of a global mental health agenda should we put together, my own experience working in New York City and Africa and Latin America really brought home the serious problem of inadequate human resources to deliver mental health services and the issue of the treatment gap, which I've already mentioned. So when we reorganized the office that I currently direct, we decided to focus on disparities locally and globally, and to do this first by addressing the most glaring inequities, one of which is the issue of the treatment gap. And in order to help set that agenda, we convened a small group of implementation researchers, representatives from ministries of health, global NGOs focused on mental health issues, and asked these people how could research best meet their needs and how might they be able to work together to ensure that research met the needs of end users. And from these conversations, we developed an initiative, the Collaborative Hubs for Research on Mental Health in Low and Middle Income Countries, which right now is a cooperative agreement with 4 funded hubs that do 4 things. First, they're meant to be a resource to the regions in which they're located for research capacity building in mental health. Each hub is composed of several countries that collaborate to that end. Second, they conduct research on task shifting for delivery of mental health services in their regions, according to whatever the local health system needs are. And third, these hubs come together to form a network so that they can ask meaningful questions across a variety of health system environments that will hopefully lead to the implementation and scale-up of evidence-based mental health interventions. And finally, to ensure that the research conducted does meet the needs of end users as best as possible, representatives of government, clinicians, service user viewpoints were included on the research team. The second thing we did was to convene the global mental health community in order to come to consensus around the grand challenges in global mental health. Why is this important? Well, global research provides us an opportunity to understand mechanisms of disorders as we include more populations in the research that is conducted. First of all, critical questions cannot be answered from data with a very limited portion of the world's population. And this is an example of, I think, research that has been conducted by taking advantage of local interesting findings. So these are data from the UK and from the Netherlands on the incidence of schizophrenia among immigrant populations. And as you can see from both the UK data, which is on the top, and the Netherlands data on the bottom, that there are specific populations in the UK, Afro-Caribbeans and Black Africans, and in the Netherlands, Moroccans and Surinamese in particular, that have a significantly higher incidence of psychosis, of schizophrenia. And investigators who've been looking at this are discovering that, and I'll just read this quote, "The relevant exposure is not the event of migration, but the context in which immigrants and their children live after migration." So again, that's a potential for a natural experiment that enables us to get a little more detail, a little more information about how disorders like schizophrenia occur and what are some of the social exposures that may lead to them as well. I'll say a word about the grand challenges in global mental health, which was, as you heard, was published in Nature a couple of years ago. This was an effort that convened more than 400 people around the world from 60 different countries, and we asked them to send us, first in text, their ideas of what are the grand challenges for mental, neurological, and substance use disorders. We used a Delphi process, which meant that we nominated this group of experts. They were anonymous, and we had iterative controlled feedback from this group. So at the first round, they could send us up to 5 challenges. We received more than 1,500 challenges, about 200 pages of text, and these were then distilled into 154 unique challenges. The panel was then asked to select their top 40. These collective top 40 were distributed for a third round, and the panel was asked to rank these by the immediacy of impact, feasibility, potential to reduce disparities, and the potential to reduce disease burden. We ended with 6 goals. But before I say that, let me just point out that this was not the first priority setting exercise, obviously. There had been several other exercises focused particularly on global health, global mental health, but those targeted primarily research in low and middle income countries. And the kinds of issues that arose from those particular priority setting activities were that there were certain priority conditions not getting much attention: depression and anxiety, substance use disorders, psychoses. There were priority populations that were not being studied much, including children and adolescents, women, and people exposed to violence and trauma. There was a need for enhancement of research capacity, training for service delivery, a need for development of evidence-based policy, and finally a need to scale up mental health services. And these are sort of images of those previous challenges. And so one of the things that was new in the grand challenges for global mental health was that it was truly global. This did not focus solely on low and middle income countries, but on the world. And that we expanded this definition to include mental, neurological, and substance use disorders. And now I'll just share with you the 6 grand challenge goals that emerged were to identify root causes, risk and protective factors, to advance prevention and early implementation of interventions, to improve treatments and expand access to care, to raise awareness of the global burden, to build human resource capacity, and to transform health systems to address these problems. And I just want to point out that these goals range from discovery science to systems and policy-related research, all of which are needed when you're addressing chronic diseases. And finally, the top 5 challenges of the grand challenges in the final round, after they were asked to rank them by the 4 priority indicators, were these: to integrate screening and core packages of services into routine primary health care, to reduce the cost and improve the supply of effective medications, to improve children's access to evidence-based care by trained health providers in low and middle-income countries in particular, to provide effective and affordable community-based care and rehabilitation, and finally to strengthen the mental health component in the training of all healthcare personnel. So I think one of the goals of the field of global mental health is to actually broaden our conception of it. So the field, I think, is first very much focused on services and implementation research, but there are other opportunities as we begin to see more research infrastructure developed in settings that have traditionally had fewer resources, and those include some projects that are currently underway. One of them that I've listed here is this, H3 Africa, which stands for Human Heredity and Health in Africa, which is a program that's funded by the Wellcome Trust and the National Institutes of Health, and it's focused on genomics research in Africa, as well as building research capacity to do this research. And there are mental health relevant projects in that program. I've highlighted here a paper on cultural neuroscience, again, a field that calls itself both old and new, which examines the bidirectional influence of culture and genes on brain and behavior. This is hot off the press. The BRAIN initiative that was announced by President Obama. And I mentioned this again because this is the kind of thing that, while certainly there are many countries that don't have the research infrastructure to perhaps do this kind of research, we need to remind ourselves that an important goal of global mental health research is to expand the populations that have the opportunity to engage in research, that we learn about the populations of the world, not just a subset of them. And finally, I think the other issue that the global health community needs to continue to pay attention to is its relevance for the larger global public health community. And I've highlighted the World Happiness Report, which many of you may have heard of, but this is a report that a number of economists are thinking about as we think about post-2015 development goals. And so there's a role for mental health in post-2015 development goals, and our research should be helping to make that case. So the take-home messages that I'll end with are that we still need to, of course, solve the unanswered puzzles of mental illness using the resources of the global context. We need to continue to develop and implement interventions for prevention and treatment of mental disorders and understand what those barriers are to implementing and scaling up when that's relevant. And certainly we have even more work to do with respect to prevention. And I think it's important as we think about research priorities over the next couple of days to remember that we should try conducting research using this new paradigm that's appropriate for a global cooperative effort that involves true collaboration and an honest consideration of power dynamics and resources in the context of conducting research. And finally, engaging the global public health community so that evidence from mental health research can be utilized fully and have the impact that it needs to have on mental health services as well as the overall disease burden reduction around the world. And this requires that we think about science, but keep science related to the society and cultures in which it is conducted. Thank you.